Hello, thanks for joining us here today. We're covering ESMO 22, and joining me is Dr. Shaheenah Dawood. Hello.
Hi, my name is Shaheenah Dawood, and I'm a consultant medical oncologist in the United Arab Emirates.
And one of the headline studies that people are talking about from ESMO this year is the interim OS data and final OS data from MONARCH-3 and MONARCHER. If we start with MONARCH-3 for advanced HR-positive breast cancer, could you talk us through some of the trial setup, design, and what those findings mean clinically?
So MONARCH-3 is one of the registration trials for abemaciclib in the first-line setting in the endocrine-sensitive setting. And it's just building upon all the other registration trials we've had in terms of Paloma as well as MONALEESA. Very similarly designed, patients with endocrine-sensitive, hormone receptor-positive metastatic breast cancer randomized to receive in the first-line setting to either endocrine therapy alone with an aromatase inhibitor or endocrine therapy with an aromatase inhibitor plus abemaciclib. Now, we've already seen the primary endpoint of this trial read out a couple of years ago in terms of progression-free survival. Very significant improvement in progression-free survival, hazard ratio about 0.5, so almost a 50% reduction in the risk of progression of disease. Now, there was a lot of interest in seeing whether there was going to be an overall survival benefit or not with this particular study, because we'd already seen that the MONALEESA trial had already read out in terms of the overall survival. We saw that a couple of years ago. And then at ASCO 2022, we saw the disappointing results of the Paloma 2 trial that showed us that there wasn't a significant benefit in terms of overall survival using palbociclib plus endocrine therapy. So all eyes was on MONARCH-3. And this was an interim analysis. Not significantly, it was not statistically significant, but there was a very, very strong trend towards improvement in overall survival with the combination of abemaciclib plus endocrine therapy, reassuring us that using a CDK4/6 inhibitor in that first-line setting has a benefit both with not only progression-free survival benefit, but also overall survival.
Do you think that trend is going to mature into statistical significance?
Well, if I had a looking glass sort of thing, I would say absolutely yes. When you look at those Kaplan-Meier curves, they are separating, and I think it's only a matter of time before it will be statistically significant. I could be proven wrong, anything could happen, but in my opinion, I think it will be statistically significant. I mean, the whole reason why there was so much interest in showing these results is because we had one negative trial and one positive trial with Paloma and MONALEESA. Now we have another sort of positive trial. We just have to wait for those numbers to pan out.
And speaking of those numbers maturing, jumping to the MONARCHER trial, we did have the final OS data there. If you could explain what that means for patients and clinicians.
So MONARCHER was a slightly different trial compared to the MONARCH trial, in that it took patients who had triple receptor positive disease. So they had to have hormone receptor positive as well as HER2 positive disease. Now, typically in patients who've got HER2 positive disease, we tend to use an anti-HER2 therapy, antibody like trastuzumab, pertuzumab, or the new blockbuster drug trastuzumab deruxtecan, and all the other tyrosine kinase inhibitors. And we tend to combine it with chemotherapy in that metastatic setting. The question that has always come up in physicians' minds is, do we always need to use chemotherapy in patients with HER2 positive disease who also have hormone receptor positive disease? Is there a way to build on a chemo-free protocol where you have an anti-HER2 therapy, you have your endocrine therapy, and perhaps adding a CDK4/6 inhibitor, which has clearly worked in patients with hormone receptor positive, HER2 negative disease? So in the MONARCHER, they had patients in the metastatic setting. It was not first line. These patients had hormone receptor positive, HER2 positive disease. They'd progressed on previous lines of therapy that combined an anti-HER2 plus chemo, and they were randomized to 3 arms. One of the arms of the study combined abemaciclib, endocrine therapy with fulvestrant, as well as trastuzumab. And then you had another 2 arms of the study. You had the standard arm, which was trastuzumab plus chemotherapy, and then you had trastuzumab plus endocrine therapy. Clearly, when we saw the results a couple of years ago presented at ESMO as well, we saw that there was an improvement in progression-free survival favoring the group of patients that we're getting the triplet therapy of a CDK4/6 inhibitor, endocrine therapy, and trastuzumab. Now we're seeing the overall survival data clearly showing us that there is an overall survival benefit when you're giving the triplet therapy, where you can add CDK4/6 to endocrine therapy plus trastuzumab, telling us that when you're looking at that triple receptor positive cohort of hormone receptor positive, HER2 positive disease, perhaps we need to start thinking about treating them a little bit more differently rather than just giving everyone chemotherapy plus anti-HER2 therapy.
Is there any reason from an adverse event perspective that there might be a patient population to not recommend that for?
No, I think that the results speak for themselves, and we have a lot of experience using a CDK4/6 inhibitor in the HER2 negative cohort. It's very well tolerated. And when you combine it with endocrine therapy, there's no increase in adverse events. When you're throwing in an anti-HER2 therapy, you don't expect there to be increased adverse events either. Of course, every drug has their side effects. You just need to be able to know how to deal with it. But in terms of efficacy and tolerability, I think it's a very good combination.
And also at the conference this year, we've got some earlier data from some phase 2 trials looking at the SERD inhibitors. If you maybe give us a brief summary on the two of those results that are presented. It was the AXL era and AMERA 3 groups.
So this year was actually very exciting because we saw two phase 2 trials focusing on two different oral SERDs. And the reason why it was exciting to look at that data was because at San Antonio in 2021, we saw the results of the EMERALD trial that looked at the oral SERD elacestrant. It was a phase 3 clinical trial, endocrine-resistant population. 100% of these patients had progressed on a CDK4/6, randomized to receive either elacestrant or physician choice of endocrine therapy, the majority of whom had received fulvestrant. The primary endpoint was progression-free survival, and there was a significant benefit in terms of using elacestrant versus physician choice of endocrine therapy. But that benefit was very modest. Now, this year, we saw two phase 2 trials presented at ESMO, the AMERA trial, the ACELERA trial, again, looking at two different oral SERDs, very similarly designed to EMERALD, except these were phase 2 trials. Patients endocrine resistant, heavily pretreated, randomized to receive either endocrine therapy, physician choice of endocrine therapy as monotherapy. Again, the majority received fulvestrant versus using an oral SERD. And disappointingly, we saw that in terms of the primary endpoint of the study, progression-free survival, very similar between the two arms. But when you specifically focused on that cohort of patients who had an ESR1 mutation, which is one of the mechanisms for endocrine resistance, we did see a strong trend in terms of favoring the group of patients who are getting the oral SERDs in terms of progression-free survival. So I thought that was very, very interesting, suggesting that we probably have to better select our patients who could benefit from oral SERDs. So when you're looking at the 3 trials in combination, I think we have enough evidence to show that oral SERDs are probably better than fulvestrant when it comes to treating patients with an ESR1 mutation who has got endocrine-resistant disease, hormone receptor positive, HER2 negative. But I think we need to wait before we start using it in routine practice. There's a lot of oral SERDs out there that are being investigated. And I think the future is not going to be the use of a single endocrine monotherapy. We've seen in the first line that in order to improve prognostic outcome, we need to use a combination strategy. And I personally believe in that endocrine-resistant cohort, we will need to look at combination strategies again. And we've seen a lot of data that's actually looking at that specific question, either continuing CDK4/6 inhibitors beyond progression of disease or looking at some other ways to overcome endocrine resistance. We saw a very interesting trial looking at a 3rd-generation selective estrogen receptor modulator, lazoxifan. At ASCO 2022, we saw the readout of the ELAINE-2 trial that looked at patients who'd progressed on a CDK4/6 inhibitor and then went on to receive lazoxifan plus abemaciclib. And it was a very nice signal that this combination was working in this cohort of patients post-progression on fulvestrant as well. So it showed us that this SERM actually worked after fulvestrant. And it also built on the evidence that perhaps we should be thinking about using CDK4/6 inhibitors beyond progression. Now, this year at ESMO 2022, we saw the readout of ELAINE-1, which looked at patients who had progressed on a CDK4/6 inhibitor, second-line study. Patients were randomized to receive either lizoxafen or endocrine therapy in the form of fulvestrant. Here, all patients had to have an ESR1 mutation. So it wasn't a mixed bag like what you saw for the oral SERD trials. And in this particular trial, the primary endpoint was progression-free survival. Now, although not statistically significant, strong trend favoring the group of patients who were receiving lizoxafen. What was even more interesting, there was an exploratory analysis looking at the clearance of ESR1 mutation, looking at using ctDNA, and clearly lizoxafen was clearing the ESR1 mutation a lot better than fulvestrant. And it also was able to clear some of the harder to treat ESR1 mutations because there's not just one type, there's several types of ESR1 mutations.
And to repeat a question from earlier, what will it take to make that trend become significant?
You need a larger trial. Elaine 1 was a signal finding study. And I believe based on the preclinical and preliminary clinical data, there's a lot of exciting trials that are coming up looking specifically at lizoxafen, both monotherapy as well as in combination with CDK4/6 inhibitors and beyond.
Okay. Well, that covers all our questions. Is there anything else that you'd like to add while we're here?
I think ESMO 2022 and ASCO 2022 have been thoroughly exciting, especially in the realm of hormone receptor positive, HER2 negative, endocrine resistant patients who have metastatic breast cancer, telling us that this landscape is evolving and giving us more choices for our patients. And that's why I'm really looking forward to some of the data that's going to come up at San Antonio 2022 this year.
Okay. In that case, thank you so much for your time and joining us today.
Thank you.